interventions in single ventricle physiology, as mentioned by the previous speakers, on stage 1, you can do something when the patient is presenting with reduced pulmonary blood flow, either a PDS stenting, or if suppose the patient has been having a previous BT shunt, a BT shunt thrombus recanalization, or a BT shunt stent angioplasty. And patients who are having increased pulmonary venous pressures, either you can do a balloon or blade septostomy or an atrial septal stenting. After stage 2, if you have a post-Glenn reduced pulmonary blood flows, if there is a Glenn anastomosis narrowing, you can stent it, PA, you can stent it, veno-venous collateral, you can close it. And if there is an excessive lung flow in the form of AP collaterals, you can close it, or if there is an antegrade flow, you can device close it. I am going to post-Fontan interventions only. Fontan failure manifests with high upstream pressures. It can lead to protein-inducing enteropathy, edema, progressive liver fibrosis. In Fontan interventions, you need to decide whether it is an extracardiac conduit Fontan using PTFE conduit, or is it Dacron conduit or a pericardial conduit, or if it is a lateral tunnel, whether the lateral tunnel has been fashioned with pericardium or Dacron. The atriopulmonary Fontan are all now obsolete, so we are not going into obsolete areas. In interventions in Fontan failure, it can be for conduit stenosis or conduit obstruction. This is an example of a conduit stenosis. A Dacron conduit is notorious for stenosis, and this is follow-up of a Dacron conduit Fontan where there is a substantial stenosis which is being stented here, and post-stenting there is an improvement in the inferior vena cava pressures. Some of these patients can have complete Fontan occlusion. This is a totally thrombosed occluded Fontan circuit due to chronically occluded thrombus. And in such cases, you can use broken bro needle, penetrate through and through the thrombotic mass, go up, snare the catheter, and once you have snared it, then you can do a balloon dilatation of the entire thrombosed conduit and put a stent and recanalize it so that the whole Fontan circulation is now again brought back to life. Fenestrations. Sometimes fenestration may have to be closed, or sometimes fenestration may have to be created. We need to understand what is the material in which the Fontan has been made. Is it PTFE, Dacron, or pericardial tube? This is an example of a patient who is having a failing extracardiac conduit Fontan. And we need to create a fenestration, and it's not very easy to fenestrate from below in a patient who is having an extracardiac conduit, because the needle will scrape through the conduit and it will enter into the pulmonary artery. It will not have an anchor at all. In such patients, you have to come from the jugular, and you will be able to perpendicularly come inside and put in a stent. And this is a stent fenestration of the Fontan circuit. But if it is a lateral tunnel Fontan, it's easy to puncture from below. This is a failing Fontan, a lateral tunnel where there is a pericardial membrane, and this membrane has to be punctured. Since the lateral tunnel is very roomy, it's easy to puncture from below, and following the creation of the puncture, we can put in a stent and create a fenestration. In some cases, extremely thick intimal peel, you will not be able to fenestrate the conduit at all, in which case you may have to come from the pulmonary artery into the atria directly from the floor of the pulmonary artery to roof of the atria. So this is a PA to LA entry, again from the jugular. So after entering with the broken bro needle, subsequently you pass a guide wire, and then you put a stent. Now this stent is between the undersurface of right pulmonary artery to the roof of the left atrium. Fenestrations are a double-edged sword. Sometimes you put a large fenestration, these patients get severe hypoxia, low exercise tolerance, paradoxical embolism, strokes, polycythemia. They may steal the blood from the Glenn circuit, that your saturation is much lower after the Fontan than when it was only with the Glenn. So here, this is a generous fenestration. When you are balloon sizing, you find that it is 9 millimeter. A 9 millimeter fenestration is a very large fenestration. So there are certain hemodynamic criteria. The Fontan pressure after balloon occlusion should not be more than 15 millimeters, and the increase of the PA pressure should not be more than 2 millimeters of mercury. There should not be a fall of the aortic pressure. The patient should be euvolemic. You cannot take up the patient in a terribly dehydrated state and say that my Fontan pressure is only 12. And patients, you have to stop the diuretics well in advance. This is a fenestration that is stealing from the Glenn circuit. We are injecting actually in the Glenn circuit, and you can find that the blood is not entering the pulmonary artery but entering the fontan and going into the heart, and that needs to be closed. If the hemodynamics do not permit a complete closure, then you have to do a partial closure. Partial closure can be achieved. This is a 7.5 millimeter fenestration, which you are making it into a 4 millimeter fenestration by putting an Occlutech atrial flow regulator. So you can appreciate here in the second picture that that large fenestration has been made into a small fenestration, and you are able to get a good flow going into the pulmonary arteries. Arrest the additional pulmonary blood flows in a failing fontan. If there is a persistent AP collateral, go and close off the persistent AP collateral. If there is a persistent antegrade pulmonary blood flow, especially in a posteriorly placed pulmonary artery, if there is an antegrade flow, go and close the antegrade pulmonary blood flow. A persistent BT shunt, go and plug that BT shunt. If there is AP collateral, close off all the AP collaterals. AP collateral closure will result in significant reduction in the left-right shunt and will improve the volume or will reduce the volume overload and improve the ventricular function. Fontan redirection. Whenever we all know that hepatic veins carry the factor X. So this is a patient who is having a left-sided Kawashima procedure. There is tremendous amount of left-sided pulmonary AV malformations that you are watching here. So this patient undergoes a surgery during which the fontan completion is given from the hepatic vein to the pulmonary artery. The hepatic venous blood goes into the right pulmonary artery and all the right pulmonary AVMs disappear. But look at the last picture, the left PAVMs are just persisting as before, and the patient continues to have severe systemic desaturation. The basic problem is like this. There is a left-sided Kawashima. We have converted the fontan by connecting the hepatic veins towards the nearest right pulmonary artery. The blood is going from the hepatic veins into the right pulmonary artery, stopping all the PAVMs, but on the left side there is persistent PAVMs. So the plan is to extend the fontan conduit so that it goes into the innominate vein in order to pump the blood into the innominate vein also, so that the blood that comes in the superior vena cava will also have hepatic factor X. But at the end of the procedure, the vertical limb is not flowing. The native hepatic venous blood is still going only into the right pulmonary artery, and it is not entering into the desired place in the innominate vein. So we create a larger lumen in the left innominate vein by stenting that left innominate vein, make it very large, and after that go and close off this wing that is between the hepatic vein conduit to the right pulmonary artery. So now at the end of the procedure, what we are doing is directing all the blood from the hepatic veins to go vertically up into the right innominate vein, go through that stented innominate vein so that it is an unobstructed pathway, make it enter into the pulmonary artery, and that is going to now perfuse both. So this is fontan redirection. So to summarize, interventions in fontan failure can be either for conduit stenosis or conduit obstruction. We can either create a fenestration or close a fenestration or optimize a fenestration. We can do a conduit flow diversion. We can address all the left-right shunts in the form of aortopulmonary collaterals, PDA, BT shunt, antegrade pulmonary blood flow. Thank you for your attention.